All of you. Welcome to the Zoom webinar on rheumatological conditions. This webinar is organized by GMOA and Society for Health Research and Innovation for the benefit of the medical professionals as part of the continuous medical education. Kindly mute your microphone and turn off the camera during the presentation and use the chat box to clear your doubts. It's my pleasure to introduce today's speaker, Dr. Dilrukshi Tennakoon, consultant in rheumatology and rehabilitation, currently attached to the District General Hospital, Negombo. Over to you, ma'am.
Problems. Thank you, and good morning to all of you, and welcome to this session on common rheumatological conditions. Now, it's not moving. Okay, thank you. Sorry about that. So now let us see what rheumatology broadly is. It is a subspecialty of internal medicine and also of pediatrics that is devoted to the study of rheumatoid diseases. They study the disorders of either the function or the structure of both of the musculoskeletal system. The origin of rheumatology can be traced to ancient times, and changes suggesting ankylosing spondylitis has been found in ancient Egyptian mummy of Ramesses II way back in 3,000 years ago. And also Charaka, who is an eminent Ayurvedic physician, has described rheumatoid arthritis in his Charaka Samhita as Vishkanta, meaning painful joints. Hippocrates himself has made observations about gout, which are known as aphorisms of gout. And here, more locally, ancient skeletons that have been found in Mata Dombalena have also shown evidence of knee osteoarthritis. So, what are the structures that are affected in these joint diseases? We have joints, the surrounding muscles, the tendons and ligaments, and the bones also getting involved. This is the structure of a normal synovial joint where you have the epiphyseal bones, and if you have a detailed look, you have the epiphyseal bone, the articulating surfaces, which are covered by the articular cartilage, and on the outer surface, we have the fibrous capsule, which in turn is lined internally by the synovial membrane. Now, these articular cartilages, the fibrous capsule lined by the synovial membrane, forms the synovial cavity, and inside this contains the synovial fluid which lubricates. For strength and stability, we have ligaments surrounding the joint, and where this ligament gets attached to the periosteum, this is known as an enthesis. Now, let us see how these patients present. They present with either pain or both, swelling of joints or both, reduced range of the motion of the joint, and features of inflammation. Because of these, there will be difficulties in function of the limb or the affected part of the body. In addition, they might have constitutional symptoms of loss of appetite, loss of weight, or fever. Now, why is it important for us to identify? We know that arthritis is common, but it is largely ignored. The significance of it is largely ignored, which will lead to accumulation of damage. Still, with our current knowledge and awareness, a large number is either undiagnosed or they present quite late. And we know that timely treatment can prevent joint deformities and other systemic complications, thus improving the quality of life, lessening the burden on the society, and indirectly the impact on the economy as well, because we know that it is the economically active workforce that is mainly affected by these arthritic conditions. So, why we want to identify them early at this stage is because we want to prevent them going into the chronic destructive latter stages. We want to prevent the systemic complications like this. So let us see how we can differentiate a person who's coming with arthritis, whether this is an inflammatory or a non-inflammatory disorder. What are the features that could distinguish? We know in inflammatory arthritis, the morning stiffness could be very significant and it is prolonged. Usually, it is taken as more than 30 minutes, but most of the inflammatory arthritis will have morning stiffness more than 1 hour. Whereas in non-inflammatory conditions, it is more focal stiffness and it is brief, lasting less than 30 minutes. Inflammatory arthritis could be associated with constitutional symptoms, and in non-inflammatory, these are usually absent. The peak period of discomfort in inflammatory arthritis is following prolonged inactivity, as opposed to in a non-inflammatory arthritis, where this is after prolonged use or activity. And in non-inflammatory, we can commonly see locking or instability due to the presence of loose bodies or internal derangements and weakness, but this is fairly uncommon in inflammatory arthritis. Symmetry is another feature which can be used to distinguish these two. In inflammatory, this is more commonly seen, whereas it's occasional in non-inflammatory. When you consider the signs, in inflammatory arthritis, the entire exposed joint area is tender. It is not very markedly tender in non-inflammatory conditions, and features of inflammation are commonly seen in inflammatory arthritis. Multisystem involvement is again more commonly seen in inflammatory as well as lab abnormalities. Now let us have a look at osteoarthritis. This is the commonest type of joint disease presenting to either the general practice or to a rheumatologic clinic. This is a leading cause of chronic disability, especially in the older adults. It's a primarily degenerative disorder, but there might be an inflammatory component arising from the biochemical breakdown of articular cartilage, but this is less marked. It could be primary, idiopathic, which is the commoner form, or it could be secondary, following trauma to the joint, or as a sequence of damage to the joint following an inflammatory arthritis. This not only involves the articular cartilage, it involves the subchondral bone as well as the synovium. The diagnosis is largely clinical and can be helped by radiographic evidence as well. So if you consider the distribution of osteoarthritis in the joints, we see that it is more common in the lower limb joints, where the weight-bearing joints get most of the load. So the hip joints, the knee joints, and it is also common in the first metatarsophalangeal joints. You see in the axial skeleton, the cervical and the lumbar spines are also very commonly affected because these are the places where a lot of movement occurs. Hands are also commonly affected. Sorry. Hands are also commonly affected by osteoarthritis, and you see here the distal interphalangeal joints, the first metacarpophalangeal joint, and the first carpometacarpal joints are more commonly affected. So how do they present? They present with a deep achy joint pain, which is of gradual onset, and this is exacerbated by activity, as I mentioned earlier. Because of this, the range of motion will be reduced and there can be crepitus. They will typically present with stiffness of the joint following rest, which is called gelling, and the morning stiffness will be of shorter duration, less than 30 minutes. As I mentioned earlier, hand OA, the distal interphalangeal, first carpometacarpal joints, and the proximal interphalangeal joints can be involved. Inflammatory changes are either not seen or they are less pronounced. Ligament laxity, muscle atrophy can be seen as the disease progresses, giving rise to an unstable joint. So this is what happens. You see in a normal knee joint, you see the joint space, the cartilage, articular cartilage, which is healthy, and the normal uh, contour. In osteoarthritis, you will see bone spurs or osteophytes forming. There'll be cartilage loss, giving rise to narrowing of the joint space. And in addition, there could be bone cyst formation as well. So again, in the hip joint, the same changes, the destroyed cartilage, reduced joint space, or narrowing of the joint space, and osteophytes. When you consider hand osteoarthritis, I told you it is mainly the distal interphalangeal joints that are involved, but you can have the proximal interphalangeal joints. Involvement of the proximal interphalangeal joints, bony swelling is called, these are known as Bouchard's nodes, whereas the distal interphalangeal joint bony swellings are called Heberden's nodes. You will see that here, involvement of the first carpometacarpal joint will give rise to squaring of the hand. This is a picture of knee osteoarthritis. You see the changes that have occurred. You see malalignment, bony swelling. This is varus deformity due to knee OA. Now, the imaging can be used to help in diagnosis, plain radiographs. But remember, when you ask for knee x-rays, always, it's better if you can get a weight-bearing x-ray because with the weight, you get the maximum changes shown on the x-rays. So we see reduced joint space, osteophytes, subchondral sclerosis, and the same is seen on this picture as well. The same in the hip joint, you see sclerosis, osteophytes, and narrowing of the joint space. Hands again, for CMC joint OA, we see subchondral sclerosis, narrowing of the space, and osteophyte formation. So how do we treat these patients? Non-pharmacological management is very important. Patient education and lifestyle modification is, the importance cannot be stressed more because we have to reduce the stress or load on the joints. Weight reduction is very important. We have to strengthen the muscles surrounding the joints. So we have to demonstrate the strengthening of the quadriceps and the hamstring muscles. This helps strengthen the joint, alleviate pain as well. In addition, hot cold therapies and nerve stimulation can be used to reduce the pain. When we consider pharmacological treatment, local applications of either non-steroidal anti-inflammatory drugs or capsaicin can be used. Analgesics, simple analgesics like paracetamol, or more potent non-steroidal anti-inflammatory drugs can be used, and as well as local intra-articular injections of corticosteroids. These are mainly to relieve pain. The place of glucosaminoglycans, hyaluronic acid, have not been established by studies, their significance, or they have not shown to be uh, changing the disease course. So these are not advocated for regular use. Those who are not responding to the non-pharmacological and the pharmacological managements can be referred for surgical interventions. There could be joint replacement, total or partial. Now, let us have a look at inflammatory arthritis. We know that rheumatoid arthritis is the commonest of the inflammatory arthritis that we encounter. We also have spondyloarthritis, psoriatic arthritis, juvenile idiopathic arthritis, and crystal arthropathies comprising the inflammatory arthritis group. When we look at a patient with, if you're thinking, could this be inflammatory arthritis? Then we have to establish that the joints are inflamed. Look for evidence of synovitis, soft tissue swelling. When you compare with the bony swelling that you see in osteoarthritis, you see that in inflammatory arthritis, the synovitis or the synovial swelling is more soft tissue swelling. There is a boggy swelling. There'll be pain and tenderness, that is on palpation, and stiffness of the joints, as well as redness and warmth, indicating that it is inflammatory. When we consider rheumatoid arthritis, we know that it is a chronic autoimmune systemic inflammatory disorder of unknown etiology. The autoimmunity plays a pivotal role in the chronicity and the progression. All of you must be aware that females are more affected, and the peak age of incidence is around 50 to 60 years. Males can also be involved, but at a later stage. Older males are involved after 70 years. The risk factors for rheumatoid arthritis: genetic, infections, especially periodontal infections with P. gingivalis, smoking, and exposure to certain chemicals have been shown to be risk factors in the development of rheumatoid arthritis. And the disease course is very variable. But we have to appreciate that if untreated, or if it is unresponsive to therapy, their deformities and destruction of the joints will occur through erosion of cartilage and bone. So we know that rheumatoid arthritis primarily involves joints in a symmetrical fashion. The upper limb joints are more affected than the lower limb joints, and out of them, small more than the large. There could be extra-articular manifestations like Zika syndrome, where you have dry mouth, dry eyes, rheumatoid nodules, vasculitis, eye involvement in the form of scleritis or episcleritis. And these patients can also have systemic involvement. That is important. It is not only the joints that can be involved in these diseases. We have to be aware that internal organs can also be involved, like lungs, where you can have interstitial lung disease, cardiovascular system, hemopoietic system, all these systems, the systemic manifestations can occur. So because of that, it's very important to identify these early and treat appropriately. What is the distribution of joint involvement in rheumatoid arthritis? As I told you, the it can affect large as well as small joints, mainly the hands. We see the main involvement in the wrist, the metacarpophalangeal and the proximal interphalangeal joints. We have the ankle and the metatarsophalangeal joint involvement mainly. Knees can be involved, and also the cervical spine. Now, the importance of diagnosing early cannot be overemphasized. We know that joint damage resulting in disability begins early in the course of the disease. When you have active disease persisting for a long period, it is less likely to respond to the therapy. And we know that newer drugs are available for treatment. Aggressive therapy with disease modifying, conventional disease modifying drugs or biological agents can control the synovitis, may even slow, even stop the radiographic progression. So, therefore, it is very important to initiate disease modifying drugs early within the window of opportunity. I will be talking about the window of opportunity later on. This will reduce the risk of bone erosions, joint destruction, and deformity, decrease the comorbidities as well as other internal organ involvement, improve patient survival and the quality of life. The same that is depicted again. This is what I mentioned, the window of opportunity. You will see that with the time progression, there'll be increased disease damage, erosions, and joint failure. And if untreated, this will exponentially go up. Once disease modifying drugs are started, this will plateau or come down, stop the progression. This is again depicted. So that's why it is important to start these drugs early when a change can be introduced. You see here the presentation, the start of symptoms here, and you see the presentation to the rheumatologist will take some time, but when the patient is presented, the start with the initiation of disease modifying drugs, you see that the damage is halted or lessened. But if the presentation is late and you start the disease modifying drugs later, you will see that there is some damage occurring, but still you have to appreciate here that even late, the initiation of disease modifying drugs will reduce the damage accumulated in the joints as opposed to the natural cause of the disease without any drugs. So, how do you identify them early when patients present to you, to your practice with arthritis? See, if you can identify them at this stage where there is very subtle spindling of the fingers. You see this spindling because of the synovitis, the synovial inflammation of the proximal interphalangeal joints. You can ask the patient to make a fist. Fisting is impaired or reduced in early arthritis. The metacarpophalangeal squeeze test can be used where you squeeze the lateral four metacarpophalangeal joints and pain is produced. The same can be used for metatarsophalangeal joints as well as a screening method to detect early inflammatory arthritis. Now, I have stressed and told you the importance of identifying these patients early and referring them early for disease modifying drugs and for proper treatment and follow up. Now, when we were medical students, we were taught of the 1987 ASIA classification criteria for rheumatoid arthritis. Now, mind you, these classification criteria are not diagnostic criteria. They are for classification, but these are used to diagnose as well. Now, here you will appreciate the main drawbacks, the criteria. The clinical criteria has to be present for more than 6 weeks. And radiographic changes of erosions are also in this criteria. So these are the drawbacks because by that time, damage has already occurred. We do not want this to happen. So that's why newer classification criteria have been introduced. The 2010 ASIA EULA classification criteria for rheumatoid arthritis have been introduced. Here we have four main domains and a scoring system where a total of 10 points will be offered. For joint distribution, you have a maximum of 5 points. You will see one large joint involvement will not score any points, whereas more than 10 joints, at least with one small joint involvement, will score the maximum of 5. Serology is uh, important, the rheumatoid factor and the anti-citrullinated peptide antibodies. So negative will not score any marks, low positives will score a lower mark, and if it is high positive will score higher marks. So this shows the importance of requesting for a rheumatoid factor titer. When you are requesting for rheumatoid factor, don't just ask for rheumatoid factor, ask for rheumatoid factor titer, because that shows whether it is low positive or high positive. The same with CCP antibodies, that will also you will have to ask for the data. Symptom duration is given 1 mark if it is more than 6 weeks, but even without that, you can still diagnose definite rheumatoid arthritis. Acute phase reactants, either ESR or CRP, is also given a mark. Now, the important thing here is patients might fulfill the criteria prospectively over time and retrospectively if you have data. So I told you about the immunology, the rheumatoid factor titer, the importance. When you take rheumatoid factor alone, the sensitivity is about 60 to 70%, and the specificity also varies around the same. Anti-CCP antibodies, the sensitivity is not very high, it's about 60 to 70%, but you see that the specificity is very high, more than 95%. And in combination, rheumatoid factor and anti-CCP antibodies, the positive predictive value of rheumatoid arthritis will be around 98%. If both are negative, the possibility of not having RA is also high at 92.5%. You can use imaging early on in the disease. Ultrasound scans can be used to detect synovial hypertrophy, synovitis, as evidenced by power Doppler studies, and the presence of effusions can be appreciated. So if you are not sure if it is early arthritis, you can perform an ultrasound scan to see whether there is active synovitis in the joint. X-rays, again, early on can show juxtaarticular osteopenia. Later on, erosions can occur, periarticular joint erosions. So very briefly, we will look at the treatment in rheumatoid arthritis. Now, as I mentioned earlier, it is very important to start aggressive use of conventional synthetic disease-modifying drugs. This has to be done at disease onset. Earlier, there was there was a misconception that you can use pain relief, analgesics, non-steroidal anti-inflammatory drugs, corticosteroids, and then if they're not responding, to go for disease-modifying drugs. It is not like that. You have to start disease-modifying anti-rheumatic drugs at the disease onset, because you want to start the treatment within the window of opportunity to stop the cumulative damage. Also, if these patients, now these synthetic disease modifying drugs can be used either alone or in combination, but if they are not responding, if the disease is not responding to these drugs, then early use of biological agents can be initiated. Now, in all these conditions, we treat to a target. What is the target? It is remission of disease. So our goal is to achieve remission, and in order to achieve that remission, we will adjust our treatment. I will very briefly mention just the drugs, some of the drugs that are used as conventional synthetic disease-modifying anti-rheumatic drugs. Most of you must be aware of methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide as the first-line agents. azathioprine, and other drugs are also used as second line agents. When you're using these drugs, it's very important for you to keep in mind that these are special drugs, they can have side effects. So, patients who are initiated on these need to have regular blood monitoring. We are not going to just continue these drugs, whether they are seen in your practice or in a clinic. They need blood monitoring and escalation or adjustment of their disease, of their DMARD therapy according to their disease status, whether it's active or uh, in a remission form. The drugs have to be adjusted. What are the common biological DMARDs that you know of? Anti TNF alpha inhibitors are very commonly used, like adalimumab, etanercept, infliximab, that are used in rheumatoid arthritis. Some of these drugs, etanercept, infliximab, are available to us as well. Then interleukin 6 blockade like tocilizumab can be used. Anti-CD20 agents like rituximab can also be used, and both tocilizumab and rituximab are available for our patients as well. So these drugs can make a huge difference for the patients. Uh, Therefore, it is very important that these patients are referred so that they get the best care. Now we come to the second group of inflammatory arthritis, the spondyloarthritis. It is a heterogeneous group of inflammatory arthropathies which mainly affects the axial skeleton. What is the axial skeleton? That is the spine and the sacroiliac joints. In addition, peripheral joints can also be involved, mainly the large joints of the lower limb and in an asymmetrical manner. Enthesopathy, enthesitis, that is involvement of the entheses, is also very characteristic. I told you what an enthesis is earlier. And dactylitis, that is the diffuse swelling of digits. Extra-articular manifestations like uveitis, cardiac involvement, and a positive family history or association with HLA-B27 is also seen with spondyloarthritis. Now, what are the subtypes or the groups that are present in spondyloarthritis? We have axial spondyloarthritis. The prototype disease would be ankylosing spondylitis. We have peripheral spondyloarthritis, where some of the peripheral features would be present without axial skeletal involvement. Reactive arthritis, usually occurring after 1 month or within 1 month of an infection. Psoriatic arthritis could be associated with plaque psoriasis, nail dystrophy. Then inflammatory bowel disease related enteropathic arthritis. You can have juvenile spondyloarthritis, and some groups can be undifferentiated as well. What are the characteristic clinical features? The pain is a dull inflammatory back pain, which is of gradual onset, insidious, which lasts usually more than 3 months, so it is chronic. There'll be morning stiffness of the spine lasting more than 30 minutes, significant feature of inflammatory arthritis. The pain here is characteristically is improved with with exercise, and it is not relieved with rest. It is worse with rest. And there could also be alternating buttock pain, and usually these patients present, these symptoms occur or start before the age of 45 years. So here you have enthesitis. Enthesis, this is Achilles tendinitis. You get plantar fasciitis and dactylitis, where there is diffuse swelling of the whole digit. So in order to differentiate and classify these patients, those who are presenting with inflammatory back pain less than 45 years of age, if you have sacroiliitis on imaging plus one or more of these spondyloarthritic features of either the inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, psoriasis, inflammatory bowel disease, a good response to nonsteroidals, family history, HLA-B27, and elevated CRP. Or if you have HLA-B27 plus more than two of the SPA features, then you can diagnose spondyloarthritis, and on the other side, peripheral spondyloarthritis, where the axial involvement is not seen, but um, there would be the peripheral involvement, either uveitis, psoriasis, enthesitis, dactylitis, and the family history. The same would be depicted here as well. So in axial spondyloarthritis, you have the non-radiographic axial spondyloarthritis progressing onto radiographic axial spondyloarthritis. When you consider ankylosing spondylitis, the modified New York criteria for the diagnosis of ankylosing spondylitis, you have the clinical criteria as well as the radiological criteria. There are three clinical criteria: low back pain and stiffness lasting more than 3 months, which is improved with exercise and not relieved by rest. Limitation of the lumbar spine in both sagittal and the frontal planes, that is, the flexion extension as well as the lateral flexion will be affected. At the same time, limitation of chest expansion relative to the normal age and relative to that which is normal for the age and sex. Along with this, we have radiological criteria of bilateral. If it is bilateral sacroiliitis, the sacroiliitis have to be more than grade 2. If it is unilateral sacroiliitis, a sacroiliitis of more than either grade 3 or 4 has to be present. How do you grade the sacroiliitis? The grade 0 is normal, grade 1 suspicious, the grade 2 you have sclerosis and some erosions. Grade 3, there'll be erosions and pseudo-widening of the joint space because of the erosions. There might be some ankylosis, and grade 4 is complete ankylosis. Now we take this as ankylosing spondylitis if you have the radiological criterion with at least one of the clinical criteria. Now, what are the changes that occur in spondyloarthritis? You see that in the normal spine, you have the vertebrae, the intervertebral discs. In early ankylosing spondylitis, you have, can I get the cursor? Right. In early ankylosing spondylitis, you will see inflammation surrounding the entheses. When these edges are involved, there'll be inflammation, giving rise to squaring of the vertebrae, and on imaging, shiny corners can be seen. In fully established ankylosing spondylitis, you will get syndesmophyte formation and fusion of the vertebrae, calcification of the ligaments. On this side, you will see that this is the normal curve with the S curve. But in ankylosing spondylitis, there will be calcification and the relative movements of the vertebrae will be reduced, giving rise to loss of normal curvature. The stooping posture would be seen in advanced disease. What are the extraarticular manifestations? You have eye involvement, uveitis is common, cardiovascular disease. In ankylosing spondylitis, you can have conduction abnormalities, aortic insufficiency, pulmonary disease, renal involvement, neurological, almost all organs can be involved, and metabolic bone disease, osteopenia, osteoporosis can also be seen. So radiographic evidence of sacroiliitis, you can use either x-rays. If x-rays are normal, you have a high suspicion of spondyloarthritis or ankylosing spondylitis. You can use MRI to detect early disease uh, of the sacroiliac joint as well as the vertebral involvement, and HLA-B27 can also be used in the diagnosis. So you see on X-rays of the spine, you get syndesmophyte formation, and later on you might get what is called a bamboo spine because of the calcifications. Here you see the sacroiliac joint involvement, grade 1, there'll be very mild sclerosis. Starting with the iliac side, you will have sclerosis and some erosions, and in grade 3 you will see, because of the erosions, the marked erosions, because of the erosions, the sacroiliac joint might appear to be widened. We call it pseudo-widening, and later on it will be fully ankylosed in grade 4. How do you treat? Non-steroidal anti-inflammatory drugs would be, for ankylosing spondylitis, non-steroidal anti-inflammatory drugs would be the first choice. If they have peripheral arthritis or evidence of enthesitis, sulfasalazine can be used. Corticosteroids as local injections for enthesial involvement or IM injections can be used. Biological agents, tumor necrosis factor alpha inhibitors, infliximab, golimumab can be used for these patients. Both are available for our patients in our clinics. And if there are, say, they can have surgical in management as well. So this again shows the management. It's very important to educate the patients, because what happens with the axial involvement, there'll be reduced movements of the spine. So exercise, physical therapy, rehabilitation is very important. We have to tell the patients to keep to exercise regularly to keep the mobility of the spine. Non-steroidal anti-inflammatory drugs for all. For axial disease, if the non-steroidal anti-inflammatory drugs fail, two can be used in optimum dosage. If that fails, then we move on to TNF alpha inhibitors. If there is peripheral disease, then sulfasalazine and local steroids, corticosteroids can be used. If they're not responding, TNF blockade will be the treatment. This again is the same depicted. So non-steroidal, we have to tell the patients about lifestyle modifications, physiotherapy, regular exercises, avoid smoking. These are very important. Then you go on to non-steroidals. If they are not responding, then you might have to go on to biological agents. Now, in the inflammatory arthritis group, let us very quickly look at crystal arthropathies. In this group, we have gout, pseudo-gout, comprising of the crystal arthropathies. Today, I will very briefly tell you about gout. Gout is an inflammatory and destructive arthritis which results from the deposition of monosodium urate crystals in the joints. This is from the extracellular fluid which is saturated with urate. So how does this saturate with urate? It's either because there is increased production or because there is decreased elimination of the urate from the body. So earlier, gout was thought to be a disease of the kings, but now it is a disease of the common man as well, because there's a drastic change. Earlier, it was associated with a more affluent way of life, indulging in alcohol, beer, wine, and all these things, and meat consumption, red meat consumption was associated with this disease. But now, because of the increased prevalence of sedentary lifestyle, our dietary habits have also changed, and more comorbidities, metabolic syndrome coming in, central obesity, hypertension, diabetes, all these have increased the prevalence of gout. Now, it's important for you to realize that gouty attacks are not related to serum levels of uric acid. So, Elevated serum uric acid level does not prove that the patient is having gout, nor does it exclude gout as a diagnosis if at acute presentation the serum uric acid level is normal. So, how do these patients present? They can present with chronic arthropathy, or they can present with recurrent attacks of acute inflammatory arthritis. This is the most commonest presentation. There could be accumulation of urate crystals in the form of tophaceous deposits, which is called tophaceous gout. These can be seen as yellow colored deposits in the pinna and also around the joints as well. And they can have uric acid nephrolithiasis. Gout presentation is very characteristic. It is of abrupt onset. The patients might report that they have gone to bed fine. They have had a couple of drinks, maybe got together with friends, had a couple of drinks, meat and all these things, gone to the bed little, I'd say, late in the night. They've been all right. Early hours of the morning, they get up with abrupt, sudden onset, excruciating pain. It's very severe. And mostly, the joints that are commonly affected are lower limb joints. And out of these also, involvement of the first metatarsophalangeal joint, which is known as podagra, is the initial presentation is in about 50% of patients. And this particular joint can be involved at any stage in more than uh, 70 or more than 70% of patients. Commonly, it initially occurs as a monoarticular disease. The affected joint is red, hot, and it's exquisitely tender. This is commonly um, misdiagnosed and sometimes confused with cellulitis of the joint or septic arthritis as well, because you cannot differentiate the two. It is that much inflamed, and the inflammatory markers are also very high. You can have um, ESRs in hundreds, CRPs in 100, 200s, as the initial presentation. When you take the natural history, sometimes these patients might present to your GP practice, and they come with excruciatingly tender joints. They are prescribed with non-steroidal anti-inflammatory drugs. They take the drugs for a couple of days, they're feeling fine, and for quite a long period of time, they'll be fine until they develop another disease. This is the natural course of the disease. It's and even without drugs, it'll be self-limiting within 7 to 10 days initially. But as the disease progresses, if it is not identified and treatment started, then the frequency of attacks increases and there'll be cumulative damage, and it'll be a chronic arthritis. The pattern might change from a monoarticular to a polyarticular, and the attacks might last longer. So this is an inflamed first metatarsophalangeal joint in gout. As I told you earlier, in the investigations, there'll be elevated inflammatory markers, very elevated. The uric acid level can be elevated, but remember, keep in mind that this could be normal as well. It's very important, if you can, to get the synovial fluid analysis. Why? One thing is because you want to exclude a septic arthritis. You have to put in a needle, take the fluid, and analyze, because you don't want to miss a septic arthritis. What are the things, what are the abnormalities that you see in the synovial fluid? Uric acid crystals, ideally they are seen in the polarized microscope as negatively biral pregnant needle-shaped crystals. These would be the crystals that you see, and the WBC would be high in the synovial fluid. In the peripheral blood film, you can have elevated WBC as well with a left shift. Other tests might show comorbidities, renal impairment. It's very important to do the renal function test. So mm, I think it's the same that is shown here. The X-rays, which shows destructive arthritis here. We see that the erosions are away from the joint line, punched out erosions. Ultrasound scan is another very important and good investigation that can be used to identify uh, crystal deposition or gout. We have the bone, the MCP head, and the cartilage. And here another, we see a hyperechoic line. We call this the double contour line, that is due to the deposition of uric acid crystals, and that is very characteristic in gout. There could also be hyperechoic cloudy areas. Uh, these resemble the wet sugar clumpy appearance, and these are uh, indicative or significant in tophaceous deposits. More advanced imaging can also be used. Now, the, the only drawback in ultrasound scanning is it is very, it depends on the performer who's doing it, on the expertise of the person who's performing the scan. Now, the management of gout, we have to manage these. It's in three stages. Namely, we have to manage the acute attack, and we have to lower the urate levels to prevent flares and to prevent the progression of the disease. In doing so, we have to provide prophylaxis when we initiate these patients on urate lowering therapy. So these are the three stages, that is acute attack management, urate lowering therapy, and prophylaxis to prevent acute attacks from occurring during the urate lowering therapy initiation. So how do we treat acute attacks? Non-steroidal anti-inflammatory drugs, corticosteroids, either intraarticular, oral, or IM can be used, and colchicine are the main drugs that are used in the treatment of acute attacks. Now, after you treat, say, in a patient who has established gout, who comes with an acute attack, if they're already on urate lowering therapy, you continue the urate lowering therapy. But if this is the first presentation, you do not initiate urate lowering therapy while the patient is having the acute attack. You have to wait till it subsides to start the urate lowering therapy. Now you see the monosodium urate crystal saturation threshold is 408 micromoles per liter. We have to keep the uric acid level in the blood below the saturation point. So the target, it's always targeted treatment. The target of therapy is to keep the serum uric acid level less than 360 micromoles per liter in gouty arthritis. But if there is tophaceous gout, then we need more stringent control. We need to keep it less than 300 micromoles per liter in order to dissolve crystals and to prevent new crystals from formation. Now we have to, once we initiate these patients on urate lowering therapy, we have to titrate our doses in order to achieve these targets. Remember, gout treatment, once initiated, is lifelong therapy. So you might have patients coming to you for follow-up. So this is important to keep in mind. So with the initiation of urate lowering therapy, as I told you earlier, there is risk of acute attacks due to the sudden changes in the uric acid level. So it's very important for you to uh, maintain prophylactic therapy for usually for about 6 months, using either the drugs that you use to treat acute attacks. The same drugs can be used, namely non-steroidal anti-inflammatory drugs, colchicine, or steroids. So, what are the drugs that can be used for for urate as urate lowering therapy? You know that uric acid forms because as a result of the breakdown of purine metabolism in the body, and xanthine oxidase is the enzyme that is responsible for a few of the steps. So, if you inhibit xanthine oxidase, the formation of uric acid will be reduced. This is the rationale behind the use of xanthine oxidase inhibitors. Allopurinol is the most commonly used first-line drug. It is available for our patients as well. Um, and for those patients who are either having side effects, allopurinol they can have allergies and interactions with other drugs, mainly azathioprine. So if they have any problem in taking allopurinol, they can be given the second line xanthine oxidase inhibitors, namely febuxostat. Then there are uricosuric agents, that is, uh, agents to promote the excretion of uric acid in the urine. Uricosuric agents, probenecid, sulfamyrazone are some of these drugs. The more commonly used drugs in our practice are xanthine oxidase inhibitors. Then uricase uh, agents, that is, uricase is the enzyme that is responsible for the breakdown of uric acid into uh, other components. This uricase is not present in the human body. We do not have uricase, so they can introduce uricase from outside in order to break the uric acid so that it does not deposit as crystals. So rasburicase and pegloticase are some of these agents. Newer agents, anti-TNF alpha inhibitors, biological agents can also be used in refractory cases. Tumor necrosis factor alpha inhibitors, anakinra, which is the interleukin 1 receptor antagonist, can also be used, and canakinumab, monoclonal anti-IL-1 beta antibody, can also be used in the treatment. Now, very quickly, because we do not have so designated pediatric rheumatology as a subspecialty, we would be dealing with juvenile idiopathic arthritis very briefly. How do these children, now it's children who are presenting with arthritis, how do they present? Commonly, they might come with joint swelling or pain, loss of function. The child may not use the limb. If the knee is involved, the child might not walk or might walk with a limp, or without any of the signs. There will be irritability and crying, or they might present with fever and constitutional symptoms. If it is a child with a single inflamed joint, you have to consider septic arthritis, osteomyelitis, reactive arthritis, hemarthrosis. Is there a clotting factor deficiency? Malignancies have to be entertained. ALL is the commonest. Trauma and also solid tumors can cause monoarthritis. Now, when we consider juvenile idiopathic arthritis, the criteria for diagnosis would be that the arthritis has to be present for about 6 weeks. And the arthritis onset should be before the 16th birthday or 16 years of age. We have to exclude any other condition that is associated or mimicking arthritis. So it is a definite arthritis of unknown etiology that begins before the 16th birthday and persists for more than 6 weeks. What are the categories of JIA? We have a few categories. We have oligoarthritis. What is oligoarthritis? Oligoarthritis is the involvement of four or the number of joints that are involved are four or less. And in oligoarthritis also, there'll be two subtypes, persistent and extended. Persistent is where it is the number of joints are less than 4 right throughout the disease process. Extended is where after about 6 months there'll be more joint involvement, and these children can have polyarthritis. Polyarticular GIA could either be rheumatoid factor negative or positive, and we can have psoriatic arthritis, enthesitis related arthritis, undifferentiated, as well as systemic onset juvenile idiopathic arthritis is a more systemic disease with maybe pyrexia of unknown origin. Now, if we consider children with uh, the age of onset in years and the types of arthritis, you will see that oligoarthritis occurs early. The incidence is more early on in the life, 2 to 3 years. Psoriatic arthritis can occur at 2 peaks. You see that systemic arthritis is also common in the early years of life, whereas enthesitis related arthritis is commoner later on, a more older child. And rheumatoid factor positive polyarthritis is also commoner in the older children's groups. Now, if you consider oligoarticular GIA, as I told you earlier, 4 or less than 4 number of joints will be affected. The asymmetrical arthritis, predominantly the lower limb is affected. As I told you, as I showed you in the picture, less than 6 years of age, early on disease, females are more affected, and most of the cases of juvenile idiopathic arthritis will fall into this group of oligoarticular GIA. The acute phase reactants could be normal or moderately increased. Positive antinuclear antibodies carry a higher risk for chronic uveitis or iridocyclitis. So it's very important to screen these children for eye complications. It's mandatory to screen children with oligoarthritis 3 monthly. So it's not just once. If you have established disease, 3 monthly by slit lamp to exclude eye involvement. And remember that these can occur, mostly develop within 5 to 7 years after the onset of arthritis. Now, if we have a look at polyarticular GIA, rheumatoid factor positive, it occurs in about 15 to 20% of patients. There can be, when you mention polyarticular, you know that the joint number is more, 5 or more joints within the first 6 months of the disease. Usually, we can have overt symmetrical synovitis of large and small joints with increased inflammatory markers, negative ANA, and sometimes they can have ANA positive early onset oligoarthritis. It resembles oligoarthritis, the ANA positive oligoarthritis, except that more number of joints are involved in these patients. So in the same way, ANA positive children, we have to monitor for uveitis 3 monthly. Polyarticular rheumatoid factor positive GIA has similar features to adult and prognosis to adult rheumatoid arthritis. But fewer children with GIA will have this subset. Primarily, girls are affected. Later on in the life, I told you it's late childhood, adolescence. It can be rapidly progressive and destructive. And this is the only category where antibodies to cyclic citrullinated peptide can be found, like in the adult rheumatoid arthritis. Now, the next subset that we would be talking about is enthesitis-related arthritis. Again, this is an undifferentiated spondyloarthritis. Typically begins early in the disease. It is more common in the boys. Lower limbs and lower limb joint involvement as well as enthesitis can be seen. Frequently, hip involvement is seen, but at presentation, sacroiliitis and spinal arthritis is uncommon. This enthesitis, what percentage of children with enthesitis-related arthritis progresses to adult or progresses to ankylosing spondylitis is still unknown. Uveitis here tends to be symptomatic. These children might have HLA-B27 positivity. Usually their ANA is negative. So when you're investigating children with arthritis, the diagnosis is usually clinical. You use the investigations to support your diagnosis. There's a misconception about the use of rheumatoid factor and ANA. It is not to diagnose JIA. It is after a clinical diagnosis of JIA has been made to either to subclassify into rheumatoid factor positive or negative polyarthritis, and also the ANA is used to risk stratify for chronic anterior uveitis. The inflammatory markers can be done. They might be high. It's very important for you to do ask for a full blood count and a blood picture, because we know that autoimmune or neoplastic causes have to be excluded, and also malignancies like hematological malignancies have been excluded. They are notorious to present with arthritis. Might have to do antistreptylizing or titer depending on the history, the other criteria, because you want to exclude rheumatic fever. Ultrasonography of the joint to establish involvement of the synovium or synovitis, and might even have to do synovial fluid analysis. Then we will move on to connective tissue diseases very briefly. Patients with connective tissue diseases, what are the categories that you know of? Systemic lupus erythematosus, systemic sclerosis, polymyositis, dermatomyositis, Sjogren's syndrome with lymphoproliferation, vasculitis, large vessel, medium, small vessel vasculitis, and also polymyalgia rheumatica and chancellor arthritis are some of the connective tissue diseases that you might have learned. When we consider systemic lupus erythematosus, or SLE, it is a chronic multisystem autoimmune disorder with a broad spectrum of clinical presentations, and it follows a relapsing and remitting course. You know, females are more commonly affected, and the disease is more commonly seen in the childbearing age groups between 16 to 55 years of age in the majority. Genetic predisposition is seen, familial clustering or higher incidence in first degree relatives of patients with SLE is seen, and other contributors would be sex hormones and environmental factors. So you see here, we have the genetic predisposition along with other environmental factors, where the patient is preclinical, in a preclinical stage, the autoantibodies are there, and with the right factors, they will move on to the clinical phase. With time, there'll be inflammation, involvement of the first organs, and then it will progress onto flares, and more damage will accumulate. Comorbidities with infection, atherosclerosis, the cardiovascular risk will be more with the progression of the disease. Now, this is a brief overview we will be discussing. So, this is just to show you that almost all organs in the body could be affected by SLE. The clinical features range from a relatively mild to a rapidly progressive disorder affecting many systems. So, it there is a chronic course with relapsing and remitting disease. So relapses and remissions can be there, as they might present with constitutional symptoms of loss of weight, loss of appetite, fatigue, and fever. Pyrexia of unknown origin is a common presentation along with lymphadenopathy. What are the mucocutaneous manifestations? These are the features that can be seen uh, from the naked eye. What are the mucocutaneous manifestations? We have cutaneous vascular lesions, photosensitivity, malar rashes, discoid rashes, oral pharyngeal ulcers, the mucosal ulcers, and alopecia. So you see the malar rash in the butterfly distribution over the face, across the nasal bridge as well. And we have discoid rashes, more discrete, coin-like lesions that are seen on the face, the hands. Then you have mucosal ulcers, the aphthei that you see usually. And you can have musculoskeletal involvement. They can present with polyarthritis. Usually they do not have chronic deformities, the correctable deformities, the Jacquard arthropathies, avascular necrosis. Cardiac involvement, we know that almost all layers of the heart can be involved. There can be pericarditis, myocarditis, pancarditis, and dysrhythmias, pericardial effusions. Respiratory system involvement, we have diffuse interstitial lung disease, pleurisy, pleural effusions, acute pneumonitis, and even pulmonary hemorrhages. Renal involvement, lupus nephritis. It can range from mild proteinuria to glomerulonephritis, hypertension, renal failure, and in neurological involvement, generalized focal seizures, cognitive dysfunction, psychosis, psychiatric disorders, myelitis, transverse myelitis, mononeuritis multiplex are some of the clinical features. Hemolytic anemia, pancytopenias, or bicytopenias can be seen, as well as anemia of chronic disease. Mesenteric vasculitis, pancreatitis, peritonitis are some of the gastrointestinal manifestations. Investigations, I'm not going to go into detail, but there'll be changes in the investigations as well. Usually in SLD, the ESR is elevated, and it is the usual is for the CRP to remain normal. If you can have high CRP in SLE as well, then you have to consider either the presence of concomitant infection or the presence of serositis. Serositis is the inflammation of the serous, that is either the pericardium or the pleura. In the presence of serositis, you can have elevated CRP. So full blood count will help you to identify cytopenias. UFR is very important. In active disease, you might have active sediments of red RBC cast, WBC cast, granular cast. These are very important. Renal involvement can be seen, appreciated by doing the renal function tests. Your serum creatinines, urine protein creatinine ratios are very important. The chest X-ray, 2D echo are important to see the cardiac involvements. The specific investigations, anti-nuclear antibody, here also I want to emphasize that requesting anti-nuclear antibodies in the clinical context. You don't go and request anti-nuclear antibodies for any patient, say for a patient with low back pain or for a patient without any clinical features. Don't go and request for anti-nuclear antibodies. Anti-nuclear antibodies, a certain percentage of the normal population can also have anti-nuclear antibodies. It is important for you to ask for the titer if you are clinically suspecting suspecting SLE. The titer as well as the pattern will be given by the laboratories. Then if they are positive, if it is positive, if you significantly considers SLE, then anti-dsDNA antibodies, anti-Smith antibodies are highly specific. We can also request for complement levels. C3 and C4 are usually reduced. Antiphospholipid antibodies if there is a risk of secondary antiphospholipid syndrome. The anti-Rho and anti-La antibodies are also performed, especially in pregnant ladies, to assess the risk of neonatal lupus involvement. Neonatal heart blocks are commoner if the mother is, it's not, the risk is more if the mother is found to be anti-Rho and La positive. Then if there is renal involvement, then renal biopsy is important. Now, you remember earlier when we were students, we used to learn the criteria, the features in criteria, in diagnosing criteria, or classification criteria rather. Um, we were told about 11 features, 4 out of 11 will be in favor of SLE. More recent, following that, the Systemic Lupus International Collaborating Clinics, or SLIC, classification criteria for SLE in 2012 has given a set of clinical criteria as well as a set of immunologic criteria. So in the set of clinical criteria, the previous clinical features of skin involvement, oral and nasal ulcers, and here alopecia has been added, pseudocyetis, synovitis, renal involvement, neurologic involvement, hematological involvement are all considered. In the immunological criteria, positive antinuclear antibody, positive dsDNA antibody, anti-Smith antibody, anti-phospholipid antibodies, the low complement levels, and positive Dilrukshi test indicating hemolytic anemia are also considered. So in this classification criteria, the presence of 4 criteria are needed. At least one should be there from either the clinical or the immunologic. That is, you can have 3 clinical criteria and 1 immunologic, or you can have 3 immunologic and 1 at least to come to a diagnosis. But remember, criteria are just to help you. The patient management has to be clinically. So it's very important, if you suspect, if some of the features are there, we have to refer these patients for a tertiary center for proper care, specialized care. And even there, these patients might need to be followed up regularly if there's a high suspicion, repeat investigations. And the clinical context also, we have to repeatedly see these patients, examine for development of newer signs and symptoms. In this, it is very important to note that if there is renal involvement and we have evidence of lupus nephritis on renal biopsy with either positive ANA or dsDNA, that alone can be a diagnostic criterion. It's a standalone criterion for the diagnosis of SLE. More recently, there have been, with the recent developments in the diagnosis and management, a scoring system has been introduced by ACRU. In this, we have the clinical domains and the immunologic domains, and a scoring system has been introduced. Now, this is not very widely used yet, but a scoring system has been used where a total score of 10 would be considered as SLE. If, say, in any domain, the patient has more than one, the highest scoring domain will be the one that is considered. So in the management of SLE, the goal is to induce prompt response to control the disease activity. And then once we have achieved acute control of the acute attack, then maintain the response and prevent flares. At the same time, we have to prevent and treat comorbidities and also drug induced damage. Now, what are the drugs that are used? The glucocorticoids are still the mainstay of treatment in acute attacks in SLE, and it is very important to know, we use this to treat the acute attacks, and once the patient goes into remission, these have to be tailed off and stopped. Antimalarials are very important in systemic sclerosis because it has, in SLE, because it has an immune modulatory effect. And unless there are any contraindications, almost all patients with SLE should be started on hydroxychloroquine and should be maintained at the lowest possible dose. Now, these doses, I'm not going to talk about these things because that is for specialized management. At the same time, depending on the organ involvement and the severity, immunosuppressive agents can be used. Cyclophosphamide, azathioprine, methotrexate, mycophenolate mofetil are some of the immunosuppressive agents that are used. And at the same time, biological agents can also be used for the treatment of SLE, namely rituximab, which is a CD20 antagonist, and belimumab, which is an anti-BLyS antibody. Now, let us quickly look at systemic sclerosis. Now, systemic sclerosis formerly was called scleroderma, but with time, people realized that it is not only thickened skin. Scleroderma means thickened skin, so it is not only thickened skin, there's systemic involvement as well. Because of that, it was the name systemic sclerosis is preferred. So it is a disease of unknown origin, which is characterized by the excessive deposition of collagen and other connective tissue macromolecules in the skin and also in multiple internal organs. So there could be fibroproliferative alterations in the microvasculature, and humoral and cellular immunological abnormalities could also occur. There are mainly two subtypes of systemic sclerosis: limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. And also two other can occur, that is systemic sclerosis, sine scleroderma. We earlier called it scleroderma, sine scleroderma, where you have systemic sclerosis without thickening of the skin. So what is limited cutaneous systemic sclerosis? The skin involvement is limited to sites that are distal to elbows in the upper limbs and knees in the lower limbs. And at the same time, face and neck can be involved, as opposed to diffuse cutaneous systemic sclerosis, where the skin thickening can be present proximal to the elbows and the knees in the limbs, and also the trunk skin can also be involved. At the same time, we have to be aware that there could be overlap syndromes where systemic sclerosis can coexist with other connective tissue disorders like SLE, rheumatoid arthritis, or myositis. If we look at limited cutaneous systemic sclerosis, I told you it is the skin distal to the elbows and knees and the face and neck that can be involved. There is slow progression of the skin and uh, late visceral presentations can be seen. In this condition, pulmonary arterial hypertension, gastrointestinal disease with malabsorption, interstitial lung disease can be seen, and commonly anticentromere antibodies can be seen in around 70 to 80% of patients. In diffuse cutaneous systemic sclerosis, the skin thickening is proximal, as I told you earlier, along with trunk skin involvement. The concomitant internal organ damage is common and early, fast progressing, in the first 5 years, and then later on it might plateau off. Interstitial lung disease and systemic sclerosis renal crisis is common. The autoantibodies that are associated would be antitopoisomerase 1, or, which is also called anti-ACL70 antibody, and anti-RNA polymerase 3 antibody. Especially these anti-RNA 3 polymerase antibody presence will increase the risk of these patients developing systemic sclerosis renal crisis. There are some poor prognostic features in patients with systemic sclerosis if they get this at a younger age. African descent, rapid progression of the skin symptoms, if there's greater extent of the skin involved, associated with anemia, elevated inflammatory markers, internal organ involvement, the pulmonary, renal, and cardiac. These indicate a poor prognosis. So let us see the skin involvement. Now, there are three phases of the skin thickening. Initially, it might be edematous. Without the thicken, you might not appreciate the thickening. And later on, it'll be indurated. And at the last stage, it'll be atrophic. So you see the skin involvement, the edematous, the indurated phase. Sometimes they can be associated with vascular changes, due to vascular changes, fingertip ulcerations. The face we can see there is due to the tightness of the skin, beaking of the nose, small mouth, microstomia, pursing of the lips, and the skin creases might be lost. Now, these are the skin involvement that can be seen in systemic sclerosis. I think here we are going to take a small break and we will resume from here after the break.
Welcome back. Let us start the session from here.
Thank you. Okay, so let's move on from where we stopped. This is the skin involvement. So let us see. Again, the slides are not moving. Let me look into that. Right, okay. Um, the vascular changes that can occur with Raynaud's, uh, that can occur with systemic sclerosis would be Raynaud's phenomenon. It's very important. These patients might come and tell you that their fingertips or fingers change color, becomes white on exposure to cold. The usual triphasic color change in fingers is needed to establish Raynaud's, that is the ischemic, hypoxic ischemic, and the reperfusion changes. Along with this, there'll be numbness and tingling or pain. And there's also exaggerated response to vasoconstriction stimuli. You see, with very advanced Raynaud's, you might even see a picture like this. Okay, now let us see the other organs that are involved. Lungs can be involved in systemic sclerosis, interstitial lung disease, and pulmonary hypertension are commonly seen. Renal involvement, renal crisis uh, is a medical emergency, has to be identified and treated properly. There could be cardiac involvement, pericarditis, myocarditis, conduction defects, and diastolic dysfunction. Reflux diseases and delayed gastric emptying with peristaltic disorders would be some of the gastrointestinal manifestations, and we know that musculoskeletal arthralgias, arthritis can also occur with systemic sclerosis. This is an X-ray view of interstitial lung disease, the lung fibrosis, the so-called lung fibrosis. So on auscultation of these patients, it's important if you're suspecting to auscultate the patients to identify the fine and inspiratory crepitations, the Velcro crackles that you'll be hearing at the bases. So on the X-ray, you will see a reticulonodular pattern, and on HRCT, if you suspect um, pulmonary involvement, interstitial lung disease, pulmonary function tests with diffusion quotient of DLCO, carbon monoxide diffusion has to be calculated. Then we can do HRCT. The high resolution CT of the chest will show initially ground glass appearance with the active inflammation, and at this stage it's important that we treat. Later on they can go to a honeycombing or the established fibrosis. So treatment is organ based as well as for the systemic disease. For vasculopathy, I think we would be going into details. So vasculopathy, calcium channel blockers, endothelin receptor antagonists, phosphodiesterase 5 inhibitors like sildenafil can also be used. The same can be used for pulmonary hypertension. For scleroderma renal crisis, it's mainly ACE inhibitors and angiotensin receptor antagonists. More potent immunosuppression would be used for lung, skin, advanced disease like cyclophosphamide, mycophenolate mofetil, and biological agents like rituximab has also been used. And for individual organ involvement, if the heart is involved, if there's conduction defects, ICD, that is implantable cardiac defibrillators, can be used. For gut involvement, mainly it is proton pump inhibitors And somatostatin can also be used for joints, the usual non-steroidal anti-inflammatory drugs, and low-dose prednisolone can be used for. So for Raynaud's, we see here calcium channel blockers would be the first choice, nifedipine. You can also use nitroglycerin patches, as well as vasodilators like phosphodiesterase D5 inhibitors, and can be used in refractory Raynaud's. Parenteral vasodilators like iloprost if there's severe uh, Raynaud's symptoms with impending digital ischemia. Now, a few words about scleroderma renal crisis. It is a medical emergency. You have to admit the patients. They have to be initiated on ACE inhibitors such as captopril, and they have to be on lifelong treatment with ACE inhibitors. If they are already on captopril, dose escalation can be done. But remember that ACE inhibitors will not prevent the development of systemic sclerosis, renal crisis. In here, it's very important for you to know that in renal crisis, even if the patient has renal impairment, you will continue with ACE inhibitors or the angiotensin receptor uh, ARBs. The When you consider pulmonary involvement in interstitial lung disease with active, one more word about, sorry about that, one more word about this systemic sclerosis renal crisis. Here, sometimes when the patients go into renal crisis, there'll be hematological changes, blood picture uh, showing micro angiopathic hemolytic anemia, a MAHA blood picture will is an indication of the patient going into renal crisis. So that might be important if you're managing this patient. Now, when we consider pulmonary involvement, interstitial lung disease with active inflammation, the ground glass appearance, you can use mycophenolate mofetil, azathioprine, IV cyclophosphamide. You can use both oral and IV, but IV will have lesser side effects. And if you are using steroids, it has to be very low dose steroids. Why? Because steroids, higher doses, have been shown to precipitate or increase the risk of the development of systemic sclerosis renal crisis. So it is very important if you are using uh, steroids, prednisolone, to keep the dose at a lower level, ideally less than 15 milligrams daily. And especially so if the patient has RNA polymerase III positivity, because there's higher risk of them going into renal crisis. Pulmonary hypertension management would be vasodilators, bosentan, sildenafil, epoprostenol are some of the drugs that can be used. And cardiac involvement, I told you earlier, if there's pericarditis, non-steroidal anti-inflammatory drugs, if there's tamponade and there's effusion, pericardial effusion, it has to be drained. If it is myocarditis, um, you can treat with, if there's no coronary artery disease, uh, we can treat with low dose prednisolone, cyclophosphamide. Skin disease also, the topical agents can be used for um, symptom relief. Advancing involvement needs immune suppressive therapy with methotrexate, mycophenolate, as being some of the drugs that are used. At the same time, you can use cyclophosphamide, penicillamine, and there are current trials going on with tocilizumab, that is an anti-IL-6 antibody, and research is being done to see the effect of antifibrotic therapies in patient management. Autologous hemopoietic stem cell transplantation has also shown good results in controlling the skin manifestations. In these patients, the gastrointestinal involvement, as I said earlier, proton pump inhibitors for reflux, and sometimes promotilions can be used for the gastric emptying delays. Now, very briefly, I'm not going to discuss all of the soft tissue problems. It's very difficult to discuss everything. One of the commonest conditions that would be encountered in a um, peripheral unit or in a GP practice would be a condition called frozen shoulder or shoulder adhesive capsulitis. How do patients present? They will present with painful, stiff shoulder, and this is of gradual onset, and gradually they will develop restriction of both the active and passive movements of the shoulder. This is the indication that it is shoulder capsulitis, because a lot of conditions uh, can affect the shoulder, limiting its movements, pain, giving rise to pain, such as subacromial bursitis, rotator cuff tendinitis. So and osteoarthritis of the joint. Uh, how do you differentiate the shoulder adhesive capsulitis from these? Is mainly because both the active and the passive shoulder movements would be limited in this condition. There are three stages where it is the freezing, where the movements are becoming limited, the frozen stage where it is very stiff, difficult to move, and the thawing stage where very slowly it will come back. They will come back to the movement. They will regain the movements. Secondary causes, so idiopathically, this can occur. There could be secondary causes also. For example, trauma to the upper limb, prolonged immobilization maybe after surgery, metabolic causes like diabetes mellitus, endocrine causes like the metabolic or endocrine causes like diabetes mellitus, hypothyroidism can increase the risk of, we see this condition more in these patients, neurologic, cardiac, for example, after myocardial infarction, after a stroke, and associated with malignancy, this condition can be seen. So, how do you manage them? Physiotherapy, hot cold therapy, home exercises, the range of motion exercises is very important. Pain relief with non-steroidal anti-inflammatory drugs. At the same time, if there's prolonged disease course, the symptoms are very advanced or the patient is suffering, then we can offer corticosteroid injections to uh, and mobilize the joint. In refractory cases, surgical interventions like mobilization, manipulation under anesthesia can be done. Now, let us very quickly look at trigger fingers, or the condition that is called finger flexor tenosynovitis. There is inflammation of the fibrotenosynovial tunnel surrounding the flexor finger tendons, which gives rise to the condition. So patients will come and tell you either it's difficult for them to uh, move the finger, or that once it is bent, it is difficult for them to straighten it out. There is locking. That is because there's formation of palpable nodules. Mostly this is due to overuse, and it can also occur in conditions like diabetes mellitus. Sometimes not a single finger, multiple fingers can be involved, and the patient might have significant stiffness of the joints, mimicking symptoms of rheumatoid arthritis. Again, here the treatment is aimed at pain relief with non-steroidal anti-inflammatory drugs. Physical measures and also stretching exercises could be used. If not responding to these, steroid injections to the area can be offered. If if they are refractory, open surgical release can be performed. So here you see it is the nodule formation and the swelling at this level that gives rise to the locking of the finger. Very briefly, let us look at decurving tenosynovitis, that is the pain and swelling of the extensor tendon, that is the abductor pollicis longus and the extensor pollicis brevis at the wrist. This is usually due to repetitive movements and overuse of the thumb. Uh, how can you diagnose? We can do a test called the Finkelstein's maneuver. That is, you ask the patient to extend. Uh, Let me show you how it is being done. So the thumb is flexed and you bend the wrist, and there'll be pain at this area. This is where the tendons are, and pain elicited at this side by doing this maneuver is called the Finkelstein maneuver. So it is these two tendons at the first extensor compartment that are involved in decurvane stenosynovitis. And also resisted thumb extension and abduction will also worsen the pain. Physical means of ice application, splinting, and non-steroidal anti-inflammatory drugs for pain relief can be used. Steroid injections will reduce the pain and the inflammation. In resistant cases, again, surgery can be offered. Now, a brief look at Achilles tendinitis. We know Achilles tendon is the largest and the strongest tendon in the body because it has to support uh, weight bearing. Because of the large size and the immense functional demands, it is susceptible to a wide range of acute and chronic injuries. Mostly, Achilles tendinitis is related to overuse. Males are more affected. Advanced age, hypercholesterolemia are some of the risk factors. Sometimes the tendon rupture can also occur, Achilles tendon rupture can also occur, leading to difficulty in walking. Main focus of management is to control the loading, weight reduction, and lifestyle modification. To protect, now how do you manage? You protect the area, you rest, ice, compression, and elevation would be the management. Stretching of the gastrocnemius and soleus and the hamstring muscles would help. Topical and systemic non-steroidal anti-inflammatory drugs can be used. Here, the important thing is glucocorticoids injections have no role in Achilles tendinitis. We do not inject Achilles tendon because of the risk of rupture. Having said that, if there is retrocalcaneal bursitis, with caution, that can be injected with steroids, but not the Achilles tendon. Please keep in mind, you do not inject the Achilles tendon. So this is the Achilles tendon getting attached to the calcaneum, and there could be inflammation of the tendon. Enthesitis is usually, if it is inflammatory, it is closer to the entheses or the attachment. Mechanical ones are more in the middle half of the tendon. So again, you see the Achilles tendinitis here. Plantar fasciitis is another enthesitis that commonly presents to clinics as well as to private practice or GP practice. It's the inflammation of the insertion of the plantar fascia onto the medial process of the calcaneal tuberosity. It is again due to maybe overuse, obesity, prolonged standing, and weight bearing. So these are the risk factors. Pain in the sole with the first steps taken in the morning or after inactivity is the symptom they come with. Investigation wise, we can do ultrasound scanning, which might show the thickening and the hypoechogenic changes and edema of the fascia. How do you treat? Again, rest, activity modification, weight reduction, splints, footwear modification. And for pain relief, you can use non-steroidal anti-inflammatory drugs. If not responding, local corticosteroid injections can be offered. So this is the plantar fascia, this insertion, it can be inflamed. So I think we have now very briefly, it is a bit difficult to go into detail when we are considering common rheumatological conditions. What the message that I want to give you is arthritis is very common. Um, Still, with the advanced knowledge, even many patients are present to us late or they ignore the symptoms. So, it's very important that we identify them early because we have treatment to prevent the progression of the diseases, to prevent the cumulative damage. It's very important they are picked up early before the damage occurs and referred for proper management. It is not just symptom relief. It is not symptom relief with the use of medications, maybe steroids sometimes can relieve the symptoms, but the disease process will go on. So it's very important that these patients are picked up and referred um, appropriately. Thank you.
Thank you very much, madam, for the excellent presentation. It's time to enlighten few queries. We have got some questions from the participants. The first question is, can we use both heat and cold therapy for the treatment of osteoarthritis? If so, when to use cold therapy and when to use hot therapy?
Usually, thank you for that question. Usually, if it is acute, for the acutely inflamed and acute arthritis, we use the cold therapy. For a more chronic uh, involvement, hot fermentation would be the preferred therapy. We can use both. Sometimes some patients respond to the hot fermentation, some uh, respond to cold fermentation. So both can be used, usually that in that manner.
Thank you, madam. The next question is from Dr. Rajapaksha. To diagnose rheumatoid arthritis, what is the level of increment of rheumatic factor in the child? Is asked.
So as I showed in my presentation, can I go back to the slides? Um, so at the moment, we have, if we go back, let me go back. Can I get the, exit the, can you go back to the, right, is what is the name? I can open this. Okay, so as I mentioned in the presentation, you will see uh, that serology for the diagnosis we have the marking system in this low positive, either rheumatoid factor or the TCC antibody, anti-TCC antibody. High positive carries 3 marks, low positive carries 3 marks. So what is the high positive? High positive is considered more than 3 times the upper limit of normal for that blood. Whatever, even you, that's why it's important to ask for the titer. You ask for the titer. If the titer is more than 3 times the upper limit of the normal, then it is taken as a high positive titer.
Thank you, ma'am. There is a few more questions to clarify. There is one more question from a participant. Is it necessary to give low uric acid containing food for gout patients?
Well, yes. dietary advice has to be given for patients with gout. I think that is one of the occasions where we advise about food. So it's very important that patients are advised not to take a lot of food containing red meat, then seafood, especially shellfish, then like mussels, then alcohol, all alcoholic beverages. You have to stress the fact that even beer, some patients might think beer is okay, only the hard liquor is not good. No, it's not like that. Beer, wine, everything, alcohol, and also even soft drinks with a lot of sugar in it, added sugar is not good. So these are the things that you have to advise the patients to limit the use of these food intake. Even sometimes drugs, some patients are on certain drugs for other comorbidities, and if a diagnosis of gout has been made, maybe certain drugs have to be adjusted. For example, diuretics, but aspirin is also known to increase the serum uric acid levels. But if the patient is on aspirin for, say, cardiac disease or some other condition where it is essential, you do not go and remove that. But where possible, drugs also have to be adjusted if the patient is having gout.
And there's another question. There are two components. One is in trigger finger, how long they have to give antibiotics and analgesics, and the other thing is what is the indication for give us steroids for the patient with the trigger finger?
Well, it is. Will they hear the question, or do I have to repeat the question?
Yeah, it's better.
Okay, right. The question is, the first part of the question is for how long we have to give analgesics or non-steroidal anti-inflammatory drugs for a trigger finger. Well, it depends on the patient. You have to give and see if they are not responding. Depends on how severe the condition is, on the response, and the need of the patient to get back to the normal activities. So it's very difficult to say you give for 2 weeks or 3 weeks or just 1 month or 1 week. It depends on the patient and the response the patient has and the need for the patient to come back to the activities. If it is really interfering with the activities, very severe pain, severely affected, then we can offer the injections. There's no hard and fast rule. Even the injections, there's no 100% guarantee that the injection will relieve the symptom. They still might need maybe repeating injections or maybe physiotherapy to relieve for the condition to be relieved.
Another thing, madam, is repeated. Repeated injections relates the
Repeated injections, there might be some damage. If depending on the number of injections, there is the possibility of damage to the cartilage. So you don't give unlimited number of injections to a single joint, and these injections are also spaced out for obvious reasons, the side effects of the steroids.
Thank you, ma'am. One more question. In patients with rheumatoid arthritis, the hypopigmented patches are caused by the DMARD treatment or it's due to the disease itself?
Sorry about that. Is it about rheumatoid arthritis?
Yes, the question is can treatment with DMARD in rheumatoid arthritis cause hypopigmented patches so it is a part of the disease?
Well, I'm not sure whether there are hypopigmented patches in rheumatoid arthritis. It is an autoimmune condition. So there could be other autoimmune conditions in association with rheumatoid arthritis. Maybe sometimes patients can have coexistent vitiligo. which gives rise to hypopigmented patches. Any inflammation that had been there can give rise to hypopigmentation, but per se, the disease or the drugs alone will not cause hypopigmentation.
Thank you, ma'am. One more question from Dr. Manjula. What are the new aspects in rehabilitation of patients in Sri Lanka?
Sorry, what are the?
New aspects in rehabilitation of patients in Sri Lanka.
Well, rehabilitation of patients now, if you're considering um, rehabilitation of patients with musculoskeletal arthritis or musculoskeletal conditions, well, um, at the moment we have medical rehabilitation specialists coming in as a new specialty. Uh, as at present, it is the consultants the consultants who are looking after this part is consultants in rheumatology and rehabilitation. They do the rehabilitation part as well. But in the very near future, we will be having medical rehabilitation consultants as well. So the rehabilitation facilities are available. We have specialized rehabilitation hospitals and units. Ragam Rehabilitation and Rheumatology and Rehabilitation Hospital is there. Digana, there is a rehabilitation hospital there, as well as in Karapitya Maliban Hospital, a big unit in Ampara, and all the other rheumatology clinics, most of them have a rehabilitation, the physiotherapy departments and the rehabilitation unit as well, for the rehabilitation of these patients as well as other patients with conditions needing rehabilitation.
Thank you very much, ma'am, for clearing our doubts. Thank you very much, madam, for clearing our doubts. And if there are no more queries, I would like to conclude this session. I would like to thank Dr. Dilrukshi Tennakoon for her excellent and informative presentation on behalf of the GMOA and Society for Health Research and Innovation. And I would like to invite Dr. Dineshan, Secretary of Society for Health Research and Innovation, to present the token of appreciation to Dr. Dilrukshi Tennakoon.
Thank you very much for the invitation.
A pleasant morning to